Okay, so in evaluating the upper extremity for somatic dysfunction, we're going to begin with somatic dysfunction evaluation for the shoulder region, which is going to include the clavicle, glenohumeral joint, and scapula. So first, of course, before beginning any kind of technique and making contact with your patient, you want to obtain consent. So is it okay if I touch you? I'm going to be touching a couple different places here on your shoulder and on the back of your shoulder. Is that okay? Okay, great. So beginning with clavicle, what we're going to focus on is the medial or proximal end of the clavicle at the sternoclavicular joint. So in order to evaluate that area, first we would have done some kind of range of motion, a gross range of motion that would have pointed us towards a likely somatic dysfunction on one side versus the other. Then now getting into the detail of the segmental dysfunction, we're going to want to palpate at that medial end of the clavicle. So now here, palpating at the medial end of the clavicle, we're going to put the clavicle through several different ranges of motion, and we're going to instruct our patient accordingly. So go ahead and raise your shoulders up to the sky. Good. And so when she raises her shoulders, I would expect the medial end of the clavicle to drop inferiorly, and then go ahead and drop your shoulders down. And when she drops her shoulders, I would expect the medial end of the clavicle to come superiorly, and then go ahead and kind of bring your shoulders forward. Good. Then when she brings her shoulders forward, I would expect for the medial end of the clavicle to move posteriorly, and then drive your shoulders back. And I would expect when she drives her shoulders back for the medial end of the clavicle to move anteriorly. So go ahead and go up and down again. Yeah, so when she moves downwards, I feel symmetric motion or symmetric superior glide of both medial ends of the clavicles. But when she raises her shoulders, go ahead and raise your shoulders up. I feel like this right side does move inferiorly appropriately, but the left side does not move inferiorly. So it's kind of stuck in that superior position. Go ahead and you can just relax there. And in those other two positions, anterior and posterior, I didn't feel any asymmetry. So the way I would now name this dysfunction, so because when she raised her shoulders, I had a restriction of motion in inferior glide, I would name that as a superior medial clavicle somatic dysfunction, because that is the preference of motion or the freedom of motion for the clavicle. Now, moving on to the glenohumeral joint, of course, we would have first started with our gross range of motion for both shoulders, and in this instance, we're going to assume that we had some kind of asymmetry pointing us to the right shoulder. Now, to evaluate segmentally, one of the kind of key elements is going to be similar to actually the same glenohumeral articulatory technique, the Spencer technique, where we are contacting and stabilizing at the clavicle and scapula in order to isolate our motion to the glenohumeral joint. So now, standing in front of our patient, stabilizing there, we can then move the arm passively into flexion, but only as far as the glenohumeral joint will allow without moving the scapula and clavicle, and then into extension, and then into abduction, and then adduction will be combined with external rotation, and we can use our arm here as a fulcrum point. And then we can also add a little bit of external rotation to feel the end feel of that motion, and then move into internal rotation, and then see what that feels like. And in all the ranges of motion, I feel like the greatest restriction of motion is actually in abduction. I feel like I don't quite get to 90 degrees, and I feel like quite a resistance at the end of range of motion. So I would name this now, if I was going to name it as a somatic dysfunction, I would name that for the freedom of motion. So if I have a restriction in abduction, I would name this as an adduction somatic dysfunction. Now, I could also name this for its restriction and call it an abduction restriction, but I have to be very careful to be clear with what specifically I'm talking about, whether I'm speaking about the somatic dysfunction or the restriction, and be very clear with whoever I'm communicating with. Okay, now moving on to our scapula somatic dysfunction. Of course, I would have started with range of motion and would have been pointed towards one scapula versus the other. So I'm going to evaluate this left scapula here. Now, making contact, I can contact the superior border of the scapula and also the inferior angle, and use these two contacts as handles here, and put the scapula through each of its ranges of motion. So it would be elevation, depression, retraction, protraction, downward rotation, and upward rotation. And I'm finding that my greatest directions of restriction are in protraction and upward rotation. So I would name my somatic dysfunction then for its freedoms of motion. So I would name it as a retraction and downward rotation dysfunction, or a scapula that is retracted and downwardly rotated. We can also evaluate both the glenohumeral joint and the scapulothoracic articulation in lateral recumbent position. So if I was going to evaluate both on this right side, then I could have my patient on lie in a left lateral recumbent position. Now here, my motions and positions are going to look very similar to, for the glenohumeral joint, to my Spencer technique. So stabilizing at clavicle and scapula, I can move my patient's shoulder into flexion, evaluating that motion, and then into extension, evaluating the end feel of that motion, move into abduction, and again, I find my restriction here in abduction, and then external rotation, adduction. Just grab my forearm here, perfect. And just to feel that end of range of motion, and then into internal rotation. And again, my greatest restriction is an abduction, so I would name that as an adduction dysfunction. Now with the scapula, I can also use the same position, have their hand kind of resting on your forearm and let the arm dangle. Now from here, you can grab the superior border of the scapula and then the inferior angle of the scapula. And from here, now your patient can be really passive and really relaxed, and will allow you to move the scapula in each of the directions. So that would be elevation, depression, retraction, protraction, and then upward rotation and downward rotation. And again, I'm finding the greatest resistance to motion in protraction and upward rotation, which would suggest a somatic dysfunction in retraction and downward rotation.